We will share the slide deck with you at the end of the meeting. Please try to remain on mute unless you are speaking during the discussion portion of the conversation. And then we also have set up our website for long-term care reform. So at the end of the meeting, you will get an email with the website. I'll also drop it into the chat. And there you will be able to find the recordings of the meetings and any supporting documents that are related. So without further ado, I will turn things over to Paul and get us going.
Thanks, Sarah, and thanks everybody for being here in late August when many people are on vacation. So it's great to see you all again, and it's a real indicator that that people are interested in this topic, and we certainly are. And good to see you all again. We spent the last couple of meetings talking about quality measures because we're doing some related work on the payment side of reform, and so thank you for all of the input for the last couple of meetings. The last meeting, if you were not able to join, was a very rich discussion of resident and family informed quality measures. And I know that the notes from that meeting were attached to the meeting today. And so definitely commend you to them. Today we're going to shift gears a little bit, and we're going to talk about quality oversight structures that exist today for nursing homes and residential care in Maine. We'll be hearing from Bill Monteo from our Division of Licensing and Certification, which plays a very important role in oversight. Brenda Gallant, the long-term care ombudsman. I think you're all familiar with the role that the ombudsman plays. You may be less familiar with the role of the Quality Improvement Organization, QIO, a health-centric, and Gail Petrie is here to talk with us about that. And if you're not familiar with the QIO's role, she'll talk more about that today. So we've structured the agenda very much in the same way that we have the last couple. We've asked our presenters to try to limit their initial presentations to 10 to 15 minutes so that we have time to get your reactions, comments, discussion on each of these components. And we appreciate that Barbara Bowers today has agreed to be our person who's going to try to sum things up at the end of the meeting. So I just offer an apology from Michelle, who has a short commitment this morning, but she'll be joining the meeting later this morning. So with that, I will turn it over to Bill Monteo to kick us off with licensing and certification.
Thanks, Paul. I was just going to ask if Sarah was going to run the slide deck, so thank you, Sarah. I'll do, as those of you who have heard me speak before know that sometimes I can go a little long. I will really make an effort to keep this high level and follow up with some additional information to Sarah related to the quality specific CMS regulations if people would like those. Next slide, Sarah, please. So the Division of Licensing and Certification is the CMS contracted state agency for survey and certification work. So we do licensing work under our state statute and state authority, and we also do the initial federal CMS oversight of 17 certified facilities, most of which are in Maine, including nursing homes. And a lot of the regulatory oversight that we do with these facilities, when we find violations, we issue what's called a statement of deficiency, but it's put into a federal database, reviewed by CMS before the statement of deficiency goes out to providers. And we'll get into some of that under the enforcement piece. But I did want to highlight to you that our role is really regulatory oversight of medical facilities and long-term care facilities in Maine. And if you go into the state statutes and actually look up long-term care facilities, it includes residential care facilities within the statutory definition. Most of us, when we refer to a long-term care facility, really think it's nursing home. And in addition to nursing homes, we also oversee assisted housing facilities, and that's a broad term that encompasses assisted living, which are apartment style individuals with apartments are assisted living facilities, and residential care, or the main care term for PNMI, private non-medical institutions, are really kind of easiest to picture them as a dormitory style living environment for our elderly, where people have a room with maybe a single bathroom or sometimes a shared bathroom, but they don't have a private apartment. And our primary role is really looking at the providers that we oversee, ensuring that they are meeting at least the minimum regulatory standards, which is what the regulations are, is considered acceptable minimum standards. We like to encourage people to kind of go to the optimum, but we can only enforce the minimum. And I know the QIO will be speaking, but they help with a lot of best practices where we look at minimum standards. Next slide, please, Sarah. And I do apologize. This is already outdated. As you know, as I noted, it's January 2023. This is the same slide that I presented to the legislature. The DLC, our division, is really three entities within our office. There's the medical facilities unit, which is medical providers, and a lot of these, if not all of these, have federal components to them. The community programs, which are assisted housing, behavioral health, and then division operations, which is the main background check, CNA registry, and program specific for licensing. And already within this, you'll note 89 nursing homes in the upper left corner. I can tell you as of today, as we speak, that number is 83. So we continue to see facility struggles. Hospitals, the 38, that's including general specialty hospitals such as psychiatric and rehab hospitals and critical access hospitals. And then the other thing to note is in Maine, we have home health agencies. We have 21. Those are federally certified. And then we have in the left-hand corner, you'll see home health care services. There's 33. Those are state licensed only. So those are facilities that provide a lot of private duty nursing, and usually have nurses that go out and maybe do the service plans or care plans for the personal care agencies that are providing services to home and community-based individuals. Next slide, please. I always get questions on what are the regulations, and these are the federal regulations and the state rule as it applies to nursing facilities, as well as the state statute, where we always go, we're in these documents on a regular basis. And as you can see, there's a lot federally for nursing homes. The emergency preparedness rule, the life safety requirement, which is handled by the state fire marshal's office. So when we're doing a recertification survey and we're visiting nursing homes on a 9 to 15 month window based on their performance, and that's a federal requirement that we do, we're looking at under the federal regulations, the requirements for long-term care. Item number 1 are the Appendix PP, the CMS State Operations Manual Appendix PP requirements, which has a lot of the guidelines and the quality measures. And we get into issues of if a nursing home has a violation or a citation for non-compliance with what's considered a quality of care, we're required to look at their quality assurance and performance improvement program. And all of that is outlined within the federal regulations. Next slide, please. So our surveys are conducted in accordance with survey protocols and federal requirements. And I will send to Sarah to share with you, there's a CMS under the current director for CMS, David Wright. David believes transparency is key. And several years ago when he first stepped into the office, one of the things that he did was transferred a lot of the training of surveyors to an online portal process. And he opened it up to providers. So when we get questions, what are the surveyors looking for? What do they ask? It is actually a very scripted process, and you can go to the federal QSEP website, which has all of the training, click on the long-term care and take the same training program that the surveyors take that walks you through what is the regulation, what is the guidance. There are certain elements where the guidance directs the surveyor to speak with the administrator and ask X, Y, and Z. So it is really a very open, very transparent process. There's no surprises. When we show up and we start the process, it follows that guidance. And all of the regulations, the guidance, the questions, who we're going to interview, it's all outlined in the process. And I do apologize. I just noticed that the revisions were updated in 2016. They actually were updated again last year. And so I will correct that. The bottom of this page is the link to the website where this material was obtained. And one thing that we are seeing, I was just at a meeting with CMS and all of the state agency directors last week in Tennessee, and the deficiencies, as I noted here, are based on violations of regulations. And one of the things that we have done for years when we do complaints was we've been kind of shifting towards away from substantiation of a complaint to it's either a substantiation of a regulatory violation or not. And what CMS is now directing us to do, and we'll be putting out soon in a guidance document, is they no longer want the state agencies using the term substantiation. You're either in compliance or non-compliance with regulations. So that will be a shift in the language that we use. Next slide. I'm not going to go into too much detail. This is directly from the CMS website at the bottom of the page, but it does help with, this is CMS's guidance on the roles of the QIO and the state agency, the roles of the QIO in the long-term care, and the survey and certification letter. CMS is really doing a lot more with quality initiatives, and they're directing us through guidance documents to the states to really take a harder look at quality, especially as it relates to if there's a violation related to a quality of care. They want to see that the facilities are really doing quality and performance improvement, and want us to be looking at that on our revisits of what is the facility doing? Does it seem to be effective? And if not, is the facility identifying it and making changes? So there's going to be a more of an increased look on the quality aspect and using data as performance improvement metrics. Next slide. I also just wanted to touch base on within DLC, we have what's called the Healthcare Compliance Operations Team, which is the Certificate of Need unit within DLC. And this unit looks at any mergers, acquisitions, new facilities or services as it relates to healthcare, substantial capital investments, and the statute directs that there's a certain dollar figure for hospitals, it's $5 million. Changing in access to services, such as if a hospital is eliminating a service for public notice requirements. And the biggest issue that impacts nursing homes and residential care facilities are beds and the increases in bed complement and the bed rights issues. We also do get involved in continuing care retirement communities, just certifying to the Bureau of Insurance that they are licensed and in compliance with regulations. Next slide. This is our community healthcare programs unit, which all of you know as our assisted housing team. And just to give you a kind of an oversight as to the lion's share of their work is residential care, with over 1,000 licensed providers in residential care, 72 assisted living facilities. And it's a little misleading in that the mental health agencies, where it shows as 174, those are the agencies, and within those agencies, they all have sites that are listed on their licenses. So these 174 agencies have roughly 2,500 sites where they actually provide services to individuals. And that's, for example, schools, school guidance counselors, or school where there are mental health agencies providing services to individuals in schools. That's a site listed on that agency's license where they're providing those services. So it's pretty broad. Next slide, please, sir. The rules and the regulatory requirements for these providers are all listed on our website. And when you go to our website, you can click on the medical facilities unit and get all of the regulations, federal and state links to nursing homes, as well as any other medical provider. Next slide. And I just wanted to touch base. Our role that we see is we do provide a lot of technical assistance. And I think some providers get confused where our technical assistance is really clarifying what the regulation is, clarifying if a violation is issued, why the citation was issued, what's the evidence that shows that it is a violation of the regulation. We do not provide technical assistance as to how to correct a violation or deficiency, nor do we provide technical assistance when there's enforcement action in place. And a lot of that is scripted through the federal process of when we've identified a violation and we're in enforcement action, the citation gives you the evidence of the regulatory noncompliance, and CMS does not allow us to provide technical assistance on what the regulation means. At that point, you should already know. And I did touch base on the substantiation noncompliance issue, where CMS is going to be putting out in an S&C to clarify to states that they no longer want us to substantiate violations of regulations. It's either compliant or non-compliant. The statement of deficiency is the written record. These are public records. So once we issue a statement of deficiency to a provider and they have received it, it is immediately publicly available. We post these on our website because CMS also posts these or makes these available on the Care Compare website. Within our organization, we do not post these until the entire case is essentially done, which means the statement of deficiency has gone out, the plan of correction has been received, a revisit has been conducted to verify compliance, and the episode is closed, and then it gets posted to our website. A plan of correction is what the facility gives us, which is what their plan and their timeline for correcting the deficient practice and coming back into compliance is. And then the enforcement actions are outlined both federally and within our state rules. And I want to highlight the goal. I mean, we've had a lot of discussion recently on, what's the goal of enforcement? And the goal of enforcement is really to get compliance with regulatory requirements. So within our organization, we do predominantly what's called a directed plan of correction, where if a provider gives us a plan of correction that does not meet the minimum standards for a correction plan, rather than issue penalties in the form of financial penalties, our preference is to issue what's called a directed plan, where we will direct a provider to do certain things, such as to hire an independent contractor or an independent consultant to provide training and education. So the goal of enforcement is compliance, not penalizing and issuing financial penalties. And then the education piece, we do training programs with Maine Healthcare Association, with the Long-Term Care Ombudsman, and we're doing a lot more. We're back to doing more now within our organization. And there's a Sentinel event team where we're doing learning collaboratives where we can't share specifics about Sentinel events, but we take the overall, what's the trend, and bring in experts and individuals to speak to hospitals, ICF, IID providers. And it's an open session on the last one we just did about a month ago at Maple Hill Farms was on trauma to secondary victims, and looking at facility staff, and what is the facility doing to deal with the trauma to its staff when a Sentinel event occurs, such as a patient comes in and goes, it gets discharged and comes back dead the next day for treatment, and the trauma that the staff suffer as a result of that. So we're doing a lot more with educational sessions. We're doing some outreach to CMS, but right now they're short-staffed because years ago we did do training sessions with CMS speakers that we opened up to long-term care facilities on CMS regulations. And it was really good to have CMS present to discuss a lot of that. A lot of this, I just to kind of close up and tie into the ombudsman and the QIO a little bit, is our technical assistance is limited to, this is what the evidence of a violation, and here's the violation, or this is what the regulation means. When we see providers that really seem to be struggling with coming up with an effective plan of correction, we can't share with them best practices or say, you know, XYZ facility had this very same issue and is going through the same thing. You should outreach to them and kind of work together. I know the Maine Healthcare Association does that, but the QIO is who we reach out to, and oftentimes we'll reach out to the QIO and say, you know, we want to refer this facility to you. These are the quality violations. We share with them the SOD. They have a lot of new staff that are still learning, and the QIO can then do outreach to the provider, and I know they'll touch on that, and share with them, review their practices, share best practices, give them guidance where we can't. Likewise, the ombudsman, we often will refer, when we get complaints, particularly from constituents, we will advise the constituent to reach out to the ombudsman, because the ombudsman's office can work with not only the family or the resident, but also with the facility to try and sometimes mediate problems. Sometimes it's education to the families. And sometimes it's, you know, working with the facility on perceptions of this is what's being perceived and recommendations on how they can address those sorts of things. So I probably went over my time, and I apologize, but I will send to Sarah, it's rather lengthy, the specific sections on quality improvement in the regulations. All nursing facilities are required to have a quality improvement plan that is data driven, and looking at their own identified quality issues and how they're addressing them. There's been discussion at CMS to the state agencies directing us to, particularly on complaints, if we get a complaint from a family and we go in and do a complaint survey and find that, yes, there was non-compliance, the facility did violate the regulation. However, the facility identified it, corrected it, and at the time that we're there, there's no longer a violation because the facility had already addressed it. Our practice has been to not issue a citation because the facility identified it before we got there, took appropriate corrective action, and they're back in correction, and there's no longer a problem going forward. There's some discussion at CMS about directing us as state agencies to document that in the statement of deficiency as past noncompliance, that the facility has violated the regulation, that they have taken corrective action, but is a document denoting that they were in fact in violation. The standard of practice that we use now with all other state agencies is we only issue a past noncompliance citation when there's a violation of harm or substandard quality of care, but this would be a new direction. So with that, I will open it up to questions, and I apologize, Sarah, if I went over.
I think you did just right, Bill. Thank you very much. We have a couple of questions in the chat, so why don't we start there? Janelle, do you want to ask your question?
Hi, good morning. I was just wondering, you had mentioned, Bill, that the training or that you provide for the surveyors is available for everyone. Is that for just nursing homes, or is that related to residential care and assisted living surveys as well?
It right now it is just federal, so it's at the CMS QSEP, so it's all federal training requirements for nursing homes, dialysis, home health, hospitals, but not for assisted housing, assisted living. Those are state only, and the requirements that we're enforcing are licensing rules and whatever's in statute. So a lot of the training of our staff when I first started in 2008, your training was initially you sat in a cubicle with 3-ring binders and read statutes and rules for 2 weeks, and then you went out with a preceptor. A lot of it is done really on the job, working with a preceptor and getting to know the regulations in the process.
Thank you.
Yeah.
And we also had a question from Maureen.
Just looking at that, Bill, my gosh, that's a huge scope of span there that you oversee. I was just wondering, do you have a specific number or ratio of surveyors at each of the different levels of care, specifically for this group, the SNF and the residential care? And then as a follow-up, how is your team doing with recruitment and retention? And is that an issue?
It is an issue. We struggle just like all of you, as this, particularly when it comes to hiring nurses. The state wage for nurses is substantially lower, and this is not just Maine, it's nationally. All state agencies struggle with the fact that the wages paid to nurse surveyors is substantially lower than nurses in clinical practice and working in facilities. And we currently, our nursing home team is a team of 11. It's was originally 19 and is whittled down over the years. But there we have, normally it's a team of 15 with 2 supervisors and a clerk. Right now it's 11 with 4 vacancies. We have some positions that we have been advertising for over a year. The number one reason people decline is the pay, for what the state offers for wage. And, you know, it's a struggle that we all do. Our acute care team, our acute care team, which is our hospital team, is a team of 6, and they oversee everything that was on that list that is non-nursing home. So home health, hospice, dialysis, hospitals, and there's only 6 staff, and right now they have 2 vacancies. So it's 4 individuals that are out there doing all of that work. And our assisted housing team is 11 with, normally they're 12 with 1 vacancy. And then we have a behavioral health team, which is a team of 4. So, you know, all total, the assisted housing behavioral health team, which is responsible for almost 3,000 sites and providers, is a team of 16. So, you know, we do triage the workload, and there are a lot of things that we're just not able to get to because of that. So we're out investigating really right now complaints that are dealing with allegations of harm or substantial harm or at risk for harm. And our process, I know the providers disagree with me, but I'd like to think of us as the QA that comes in. We're the fresh set of eyes that looks at things and tells you, here's something that is not in compliance with the regulations, and this is why, and give you the opportunity to fix it. I know it's viewed as punitive, but it's rare that we issue fines or citations. CMS does if it's at a harm level or a significant risk for harm. But CMS also uses that money in the form of CMP money to come back and help with benefits to the residents, and CMS contracts with the QIO to help provide guidance to providers. So, and I know Gail will talk about it, but facilities, we encourage them to reach out to the QIO directly. You don't need a referral from our office to get involved with the QIO.
So my last was a comment, not a question really, but it seems as though citations of past non-compliance that a center has identified and made corrective action just seems to fly in the face of the whole quality improvement process. And so just had to say that.
I understand. And I, you know, as a regulatory agency, I understand if there's harm involved in the issue of citation for past non-compliance, because for nursing homes, there's a penalty involved, and that the financial impact for that penalty is limited to the time period where you were in non-compliance. So we want to document, yes, you were out of compliance, and then you immediately addressed it and were back in compliance within 2 days. So that limits the imposition of a fine to that 2-day window, versus if it was a 3-month window and the facility didn't take corrective action, the fine is pretty large federally. So Maureen, I understand. And that's why the state agency directors, this is a new direction that CMS is directing or indicating that we should be going in, and we're waiting till we see that memo in writing before we impose that. Right now, it will be the same. If there's non-compliance that involve harm or jeopardy or significant risks, it will be cited, and we have an obligation to make sure that we document as part of that citation the corrective action and when it was corrected.
Ruda?
Yep.
Thanks, Paul. Yeah, this is kind of a follow-up to that last point. It seems to me a lot of this is really about a matter of degrees, like how severe was that harm, and I really appreciate the overall philosophy you described, Bill, of, directed plans of correction and the goal being to achieve compliance. At a certain point, I imagine if there is repeat non-compliance or sort of disregard for the things that need to be happening, then I would think it is appropriate for CMPs to kick in to sort of get attention, if you will. So I think a lot of it is, I appreciate your role as being challenging and involving a lot of gray.
It is. And also along that same line, when we go into a nursing home and we send a team in January for an allegation of abuse, and what they find is it really wasn't abuse, but was something along the line of a dignity issue or a lack of training on the provider. And there's a citation, not for abuse, but for some other quality issue. We go back and do a revisit and find that they've taken corrective action. If we get a complaint or do a survey and we're back there 9 months later and we find the same issue, we will issue what's called a QA tag and say, okay, we cited you 9 months ago, you took corrective action. We now have the same problem. Your quality assurance committee failed to ensure that you had a sustainable plan and failed to identify this. So now you've got not only a repeat citation, but a quality assurance violation because your quality assurance committee was ineffective in monitoring this to ensure sustainable action. It's not something we would do, if we cited a provider and then went in 3 years later. We don't do that, but certainly in that 9 to 15 month window between those recertification windows, repeat violations are automatically a quality assurance tag, because what we want the facility to do is to identify it before we do.
And we've got a couple of things from Rich. Rich, do you want to jump in?
Sure, thank you. Bill, I was just curious, do any states employ physicians or NPs or PAs, so a medical provider as part of the state survey process? I try to be involved in the exit interview and just the whole process, but I know it's not probably necessarily the standard or common. I'm just curious about that. And then my last other comment was, the scope and severity. I think, sometimes I can understand the deficiency, but I think the debatable part sometimes is the scope or the severity of it. And because it is kind of subjective, and I think that obviously the nursing home is going to say, well, it's not that widespread, and I think there's probably a tendency to say things like that, but it just seems like, and I know that we don't have a lot of control because these are CMS things, but it seems like a more subjective part of the survey process and not objective.
First question, Rich. Yes, we have a contracted physician who works with us. Dr. David Stuchner is our contract physician.
Okay.
He's very involved in the hospital surveys, and we're expanding his scope to get more involved with nursing home. We did recently have a nursing home complaint where we had a team investigating allegations at a nursing home, and we had Dr. Stuchner and another individual who was familiar with the nursing home regulations at the hospital, looking at the care at the hospital and for the same patient, because it involved both entities, and really how was information shared between the hospital and the facility regarding this patient. So Dr. Stuchner he's not a state employee, he's a contract physician. And that's how most state agencies utilize their physicians. It's hard to get a physician, to be a state employee.
Sure.
And as far as your second question, the scope and severity is there's guidance that CMS gives us. And yes, you're right in the fact that it is not as objective as many people would like. It is somewhat subjective. But it's also whenever there's a violation of F level on that scope and severity or higher, it's reviewed by CMS. And sometimes we disagree, and CMS will scope things higher. I will share with you that I struggled for years with the fact that something that has potential for death or serious injury is a higher severity than something that actually causes death or serious injury. And that's a G level citation means that there was harm to the resident. Well, a higher severity is the potential for significant harm. So even if you didn't harm a resident, but it had potential, it's more severe on that CMS scale than actual harm. So, that's CMS's process. And when there's always what's called an IDR, an independent dispute resolution process for facilities, but under the CMS term, you really can't dispute the survey or judgment. You can dispute the facts or findings.
Yeah. Can I just have one more follow-up about because I was unaware that there's actually a contracted physician. So is there an ability for a medical director to sort of make a peer-to-peer discussion regarding some of the violations that occur, or some of the findings in the survey process?
No. If Dr. Stuchner is involved in the survey, that discussion can happen before the end of the survey, but not after the fact. Okay. The only process would be an informal dispute resolution on the findings.
Okay. All right. Thanks, Bill.
We have time for one more before we move on. And Barbara, do you want to pose your question?
Yeah, I was just curious about how you involve residents. Say a resident has made a complaint and you're investigating it. Is there guidance? Is that sort of subjective, situational, both during the investigation, but also talking to them about the resolution?
There is guidance, Barbara. And the process is when we're doing surveys, there are residents are chosen at random based on the MDSs. So the CMS software essentially picks residents based on quality measures that are indicated in the MDS assessments that facilities submit. Then about 10% of the survey sample are chosen by the surveyors based on their observations of what they see or hear. And then when they're doing a recertification survey, they're supposed to meet and discuss with at least 3 family members. They do interviews with family members, and there's guidance that CMS says, when you interview the family member, please ask about X, Y, and Z. All residents that are in the sample are interviewed unless there's evidence that they're not cognitively with it and not interviewable. And that is a CMS survey requirement. So when we're doing a sample of 20 residents as part of a recertification survey, all of those residents are interviewed. Now, when we do a complaint, we have to get a sample, and it's usually in the nursing home, the minimum standard is 3. And what surveyors will do is if I've got an allegation of abuse, the facility is abusing my mother because they're leaving her wet and soiled. The surveyors will do they will call the complainant first, either at the facility or before going to the facility, and interview the complainant. When they go to the facility, they will take a random sample of residents, at least 3, and include at least one, the individual who was named as part of the complaint as part of that sample. And they will interview those residents and look at their care plans and their service plans and observe their care. And if they find a concern, they expand and enlarge the sample. They'll go from 3 to 6. And if they find more concerns, because what they're looking for is systems issues. They're not individual private investigators. They're trying to determine, is there a violation? And if so, is it isolated to this one, or is it a systems issue? And the standard that we tell providers is whenever there's abuse, if you fire the individual that's alleged to have abused them, you haven't really fixed the problem. You've just ensured that individual won't do it in your facility, but you haven't looked at the root cause as to why. Did staff fail to identify this individual? Were they stressed? Were they overworked? So yes, residents are interviewed, families are interviewed, but we're never at liberty to discuss or disclose who the complainant is or who is the subject of the survey or the investigation. The exception to that is when the facility self-reports. If a facility self-reports a resident-to-resident altercation, we can call the facility, because they are the reporter, and have a discussion with the facility to determine, do we need to go on site, or is the facility addressing this sufficiently?
Bill, also in the annual surveys, there is the meeting with the resident council and any residents who want to attend. And then I think the other thing that is nice is the signs that you have to have us post on the doors, which basically, so somebody coming in or looking at the door, it'll say they're in the building, you can talk to them, or you can call them at this number if somebody doesn't feel comfortable going right to a surveyor. I think there are some processes there.
All right. Well, thank you very much, Bill, and thanks for the discussion. I learn something new every time I hear Bill speak, so I appreciate very much your giving us some time today. We're going to turn to the Ombudsman, and I misspoke. Gretchen Zay-Higgins is actually going to present for the Ombudsman today. So Gretchen, take it away.
All right, thanks, Paul. So yes, I'm not Brenda Gallant, and I'm not the Executive Director. Gretchen Zay-Higgins, and I'm the Associate Director with the Long-Term Care Ombudsman Program. As you all probably know, in 1978, amendments to the Older American Act established the Ombudsman Program in every state across the country. Maine also has state enabling legislation for LITCOP to provide advocacy for residents in both nursing homes as well as assisted housing. And that's to investigate and resolve complaints. We also have state enabling legislation for our program to provide advocacy for patients in hospitals who experience barriers in accessing long-term services and supports. Maine is the only state in the nation, I believe, that has the hospital program as well. And some of the barriers that we encounter could include barriers related to dementia, somebody who might need bariatric care, the need for one-to-one support, or transportation for dialysis has been a big one, ventilator care, somebody who might need trach care. Next slide, please. So some of our advocacy and outreach, we visit 335 long-term care facilities across the state on a quarterly basis, and more frequently in response to complaints and concerns of quality of care or quality of life issues. Our visits are conducted by both staff and volunteers. As you can imagine, volunteers were very difficult through the COVID pandemic, and we're just now starting to ramp that up again, which is really nice. When we identify trends in quality of care issues or poor surveys, we do increase the frequency of our visits. So from January 21st of 21 to July 17th of 23, we visited 27 long-term care facilities on a minimum of a monthly basis due to poor survey results. We also worked very closely with licensing and certification to communicate concerns and work collaboratively. And we do also work with the quality improvement organization, Health-Centric Advisors, to address issues with quality of care. We establish family councils, and we advocate for residents during the process of facility closures. And as you can see, in January of 21 to July of 17th of 23, there was 26 facilities that closed, in which we worked closely with family, staff, residents to relocate those residents, whether that be to another facility setting or to return to the community. Next slide, please. So this pie chart just shows the complaint data that we received for residential care communities between the dates of October 22 and March 30th of 23. Total of 255 complaints, with the highest complaint coming in at 32.1% for care concerns. Next slide. And this pie chart is our nursing home complaint data for the same date range, 357 complaints. Again, highest complaint being care concerns, coming in at 42.2%. So nearly half of our nursing home community complaints are related to the care concerns. Next slide, please. So this slide is really just giving some examples of some of our advocacy work. The first example here is regarding an individual who needed assistance moving into a nursing home. This was an individual who did require dialysis 3 times a week. She was petrified of being home alone and dying alone in her home. Prior to contacting our organization, she was told that she wouldn't qualify for a nursing home and she would not be able to access main care. We was successful in establishing her main care and her nursing home eligibility. We was able to locate a nursing home close to her family, and we was able to secure transportation for her dialysis treatments. And the second example here is regarding a nursing facility where we received a multitude of complaints from both residents and family members. And again, it was regarding the care. So we was able to work with the facility administrator. We met with residents, family members, conducted several family councils. We worked with licensing and the QIO, all collaborative effort for advocacy. And over time, we did see some improvement. That was a long haul. That was probably close to a year, if I recall. The last example here is an individual who suffered from dementia, and she had some significant behaviors related to the dementia, and she wanted to return to her state of Maine from an out-of-state facility. So we was able to secure placement for her here in Maine and bring her home. Next slide. As you are all aware, collaboration is crucial to all of the work that we do. So this is just a list of some of the entities that we work closely with on a regular basis. Next slide. So in early October, we've been working on a bunch of different initiatives and different campaigns. And in early October, we partnered with Ethos, the Maine CDC, and DHHS to launch the Power of Care campaign. Power of Care campaign. The slogan, if not for you, then them. So this campaign, what we're doing is we're using ambassadors to really provide a peer-to-peer approach for individuals working in direct care to be able to really speak with their peers about the importance of vaccination for direct care workers. We do have a website for this campaign, and that is called the mainpowerofcare.com. I can drop that in the chat after too. And this campaign is ongoing. Next slide. We also are working on the Maine's Workforce Initiative, which is a grant from Maine Healthcare Access Foundation, as well as funding from Office of Aging and Disability Services. And again, we partnered with Ethos for this campaign. And the purpose really is to engage and empower direct care workers to learn about what challenges they're facing in the field, how we can help support them moving forward. Next slide, please. So as part of the focus group, we really wanted to hear from the individual direct care workers across the state. Again, to understand what are their most pressing issues, how can we help them move forward? Through this process, there was a total of 10 virtual focus groups that was conducted from November 21 through January of 22. And in total, 58 direct care support professionals participated in those focus groups. Next slide, please. So some of the recommendations that came out of the focus groups, one was to form the Direct Care and Support Professional Advisory Council. That council was established in February of 2022. And again, the purpose and another recommendation here is really to elevate the status of the direct care support professionals, particularly in the eyes of the public, but also employers and policymakers and payers, really with the objective to increase wages and benefits over time for that group of professionals. Currently, Ethos is working on creating the Walk in My Shoes documentary, A Day in the Life of Maine's Direct Care Professionals for us. And again, this is really, we're trying to highlight the challenges that these individuals encounter on a regular basis. And of course, this is to promote entry-level direct care work, and really encouraging people to start here in healthcare. We need to be able to change the way the profession is viewed. It's a really important and crucial role in our facility-based settings, and it's important that we implement policy to provide more support for these individuals. Next slide, please. So these are some quotes from the group participants, and a couple of powerful quotes. So the first one here is, I love care. I like caregiving. It's just in me to want to take care of people. It makes me feel good at the end of the day as well, knowing that you help someone meet their needs to give them quality of life. The people who are in these homes and doing this work are angels walking this earth, but there aren't enough of them. Sometimes I get told I care too much. How can you care too much for a human being? Next slide, please. So the advisory council is made up of 17 direct care support professionals, and that's from across all LTSS settings. And on the next slide, you can see the faces of those advisory council members. They all have a story behind them to tell. Next slide. So in collaboration with PHI, the council members were able to attend 4 of the interactive training sessions. And really the focus and the purpose of the training sessions was to help the individuals build confidence in telling their story so that they could go before policymakers, employers, and the public and have their voice be heard. And the chart on the bottom here, what we did was we surveyed the advisory council members to find out what was important to them for trainings, what is going to help them tell their story, build their confidence. And interestingly, the top 3 are the legislative, learning the legislative and policy process in Maine, understanding and impacting the state budget, and using social media to advocate. So that tells us the story right there, because that tells us they do want to make their voices heard. They do want to go in front of policymakers and let them know what's needed for them to be more successful in these professions. Next slide, please. So some of the council activity. Since the council formed, they've been able to meet with representatives from the Office of Aging and Disability Services. They've served as a panel, on a panel for the Maine Association for Community Service Partners. They were able to participate in the Division of Labor's Caring for Maine campaign. They met with Maine's Women's Lobby and discussed the Family Medical Leave Act, participated in the campaign to promote the new Helping Voice Warm Line. And again, they participated in the Power of Care vaccination campaign. The training sessions that I just spoke about. They also attended a presentation in February of 23 before the Health and Human Services Committee and the Caucus on Aging at the State House. Some of them also did submit testimony on LD 1718 and 1521. And then there were 2 council members who served as panelists at the Leading Age Conference in Portland in April of 23, which I don't think is on that slide. And I shortened it up to take up the room that we gave Bill. So questions?
Thank you, Gretchen. I would just comment that I know from talking to other aging and disability directors around the country that we're fortunate to have an ombudsman program that is so innovative. You can tell from Gretchen's presentation that they are more than willing to go beyond the traditional federally required ombudsman role and always partner with us, like on the vaccine initiative, et cetera. So thank you. And also, unfortunately, we have had significant number of closures in the last few years. The ombudsman role in that process is absolutely critical, and we appreciate it. Rich.
I just wanted to talk a little bit about the hospital advocacy part of this and getting people into long-term care facilities, because I'm the medical director at St. Joseph's in Portland, and it's a part of Maine Health, and we take, I would say, a significant amount of long-term care patients from the hospitals, and a lot of facilities don't do that. I understand on paper that some of these individuals look very challenging, but this is our area of expertise in terms of dealing with some of these individuals, and the hospital environment artificially creates some of these behaviors because they require them to stay in bed, and they're put on a one-to-one, and the worst thing that could happen in the hospital is that they fall, and so they do everything possible to make this person to do these things, and it causes other complications, and they use high doses of psychotropic medication. So I really, I would say 90% of these people that look difficult on paper fit right into the nursing home setting and thrive and do better because they're allowed to leave their room. They're allowed to eat in a community setting. They're allowed to go to activities. They're allowed to go outside. They're allowed to go out with families. And I tell people, yeah, this isn't prison, because the hospital makes it seem like prison-like. So I don't know how to advocate to do that, because the hospitals are full of people that don't need to be there, and it's significantly impacting their quality of life.
I totally agree with you. What we often see is that the treatment plan that's developed in the hospital is not transferable to a nursing facility. And that puts up huge barriers. And then we also see some of the documentation that comes from the nursing facilities, not the nursing facilities, but the hospitals, sometimes does create a barrier to placement. And while it might be appropriate documentation, it goes beyond just reading that documentation. We really need to look at the whole picture of the individual and what's causing a particular behavior. And unfortunately, sometimes you're right. We'll try to admit somebody into a facility, and the facility only sees what they see on paper, and they can't get beyond that. So it's really, that's where we really try to step in, and we try to advocate and work with the families and the facilities and the hospital, and try to pull groups together and say, how can we make this work? What treatment plan is transferable? Because we know they can't go on an IM injection, or they can't go on certain medications. So how can we change their treatment plan to make it a transferable treatment plan?
We should take you on an ambassadorial tour of other facilities, Rich, to let them know that they really can serve these people.
Paul, I've talked to the Senior Living Collaborative countless times about this, and people, I don't know, and I frequently hear, well, this isn't the right place for them. I said, there is no right place for most of these people. We're taking care of younger people with more psychiatric problems, with more, substance use disorders, with chronic diseases that are occurring at younger ages. Geriatrics is not geriatrics anymore. We are caring for those. We're really chronic disease specialists. And so we really need to kind of figure out a way to how to advocate for these individuals. One gentleman who even my own facility wasn't willing to take for over a year, because of everything he did, he just kind of blends into some of the other cantankerous people we have here. But he's doing just fine. And I saw him sitting in the courtyard the other day, and I was like, I had to do a double take that he was sitting outside at an activity. I was like, this is fantastic.
Yeah, would others like to jump in here? We've got Barbara and Ruta and others making comments.
I would just like to say that this, what you bring up, Dr. Moreno, really strikes me as what I've suggested in the past to both Maine Healthcare and Maine Hospital Association, is that those two associations need to get together and really kind of work collaboratively to see how they can address this very issue of how do we get the people that are backed up in the hospitals into nursing facilities. And some of it is, as Gretchen said, maybe it's looking in more detail at how do we change the care plans or the care environment or transition them. Because I frequently, as licensing, I get the calls of XYZ facility refuses to take them. What can you do? And I can't do anything. I mean, that's not a licensing role. But those two associations, where they represent hospitals and the nursing home industry, I think would be ideal to work together collaboratively to come up with something.
And I just want to add in that venue that APIC and the nursing homes are trying to start to work together, because there was an identified concern with transitioning people out of the hospital with infectious diseases. And so, we're trying to put together a group that if there's a difficult transition right now regarding someone with an infectious disease, if you could reach out to me, because we'd like to kind of pull the players together and kind of, talk it through. Yeah, I remember the old days that we would go to Maine Med and do kind of case reviews of some of these difficult people. And maybe we need to put together some work groups. And I think Gail is on the call, and I know we've got a meeting coming up on transitions of care. So maybe Gail can offer some information on that.
I do think there's also an issue with medical directors. I know AMDA in particular is trying to at least get CMS to list the medical directors or to require facilities to do that, which is not being done. And they didn't seem to be very interested in doing that. But I mean, Rich, you may have a comment on this. Some of the things you're talking about actually require somebody who's paying attention in the facility. And that's clearly not always the case.
Can I just jump in to say one other thing, which is, I mean, first of all, I think it's really important that we think about what's happening in the hospitals too, because that care that Rich just described is not appropriate and could have long-term consequences for people. The other is kind of hearkening back to our last conversation about quality measures. I think it highlights the importance of thinking about unintended consequences and balancing measures. So, if you tell people no one can ever fall, what will happen is no one will get out of bed. And so balancing fall measures with mobility measures or some such thing is really important to be thinking about, because we'll see exactly the same thing in the nursing home as we're seeing in the hospital.
Yeah, I think we should talk about maintaining mobility while preventing falls rather than the flip. Get people thinking more about the mobility. I also think the communication in both directions, from the nursing home to the hospital and back, is really problematic. In many places, people in both sides say we sent information, but it never arrives. So they're guessing about what to do with somebody. And I think probably a lot of harm results from that.
I agree with you, Barbara. And I also think that part of the challenge that we see is when a referral is sent, it's sent through a computer system. And there's no real discussion about, yes, this is what you're reading on paper, but this is our experience with the individual.
Right.
And I think that's a true barrier, because once we get involved and we learn more about the experiences with the individual, and we have those conversations with the nursing facilities, and we pull the parties together and there is conversation, that's when we have success in placement, not when we push a button on a computer. So communication is key.
Yeah, we did a study several years ago looking at the communication across. One of the biggest challenges was nursing home staff trying to get information they needed, and they couldn't go into the records. They were closed, and they were trying to find the staff who actually knew the patient, and they couldn't get access to anybody. So there's a real issue. It just cut off.
Mm-hmm.
On a good note, we are one population that seems to be having some movement and more ease getting placement is the opiate use disorder and the Suboxone patients. So more and more organizations are more and more willing to take these individuals. And we even at St. Joe's are very creative with our methadone. We have 2 that are actually on methadone that go out to the clinic for take-home privileges, and we just keep them secured. So more and more organizations are looking at this population, and the stigma is lessening. So that's good.
That is good. Thanks for sharing that good news. Mary Lou, do you want to jump in here, and then we will move to our last speaker?
Do you want me to jump in on the direct care worker advisory council?
You had commented on the innovation that we're seeing in our ombudsman program, and there was a little while back some discussion of that.
Oh, yeah. Well, just to just to follow up on the Direct Care Worker Advisory Council, it is innovative, Barbara, and I have been talking with Brenda and Nicole Marchese about the importance of just, doing a basic evaluation work, collecting a little bit of data so that it could be replicated in other states. It's so important for that voice of the direct care worker to get to policymakers, and we've all been so frustrated with this over decades. But Maine has taken some very important early steps. So I'm just going to keep chatting with LitCop about that because it's important.
And Gretchen, correct me if I'm wrong, but I think that there's going to be a presentation at the HCBS conference around the council next. Is it next week or the week after?
I believe it's next week. Yeah, in Baltimore. Yeah.
So other states have been interested. We did talk about that at the HCBS conference last year. So states are definitely interested in hearing more about the model.
So thank you, Gretchen. And let's move on to our final speaker today, Gail Petrie.
Hi, everybody. Worry not about the time. When I'm nervous, I talk really fast. So we'll end on time. I just wanted to say a couple of things before I jumped into the slides. In response to the comment about the innovation coming out of the Ombudsman's office, I would just want to second that and say, we've developed a tremendously strong, positive relationship with the Ombudsman. And right now we're exploring how to bring more CNA training to Maine. We just did a program for the last 8 months here in Rhode Island, and we managed to get 165 new CNAs out of the program, which is more CNAs that have graduated in the last 3 years. So hopefully we can replicate something like that. I also wanted to just say something quick in response to the doctor's comments about caring for individuals with opioid use disorder. And so outside of our QIO work, we're also a private contractor. And we've done a tremendous amount of work in Massachusetts developing an MOUD toolkit and trainings for the nursing homes. We're also an independent oversight evaluator for a corporate chain that cares for folks with OUD in Massachusetts. And we're right now in discussion with folks in Connecticut to replicate some of that work in Connecticut. So it is becoming a big area of focus. And in response to the Safe Care Transitions meeting that was brought up, so we convene groups in all of the states that we work with, and the pandemic really played havoc on the sustainability there. So we're relaunching a lot of that work. We've had one meeting. There's another meeting coming up. We recently did it in New Hampshire, and it really it really doesn't need to be sort of complicated. I think you guys already touched on a lot of the stuff as far as, it's about communication. It's about relationships. It's about having a face in your head when you pick up the phone to call somebody and start talking about patients. And there's been so much staff turnover that folks don't know each other anymore. And, we recently had a big meeting in New Hampshire with nursing homes and hospitals, and some of the things that came out of it that were really important to people were things that could be done by next Tuesday. That these weren't big, complicated things. Some of them were really easy wins. So I'm looking forward to continuing those conversations in Maine. Okay, you can go to the first slide, please. So Health-Centric Advisors is part of the iPro QIO. In this scope of work that started in 2019, we partnered because CMS allowed organizations to bid on much larger swaths of the country, could up to representing 20% of the Medicare beneficiaries in a region. So we did partner with iPro. They oversee New York, New Jersey, Ohio. We handle all 6 New England states, and another organization, Clarent, out of Maryland, does Maryland, Delaware, and DC. Next slide. So the significant challenges facing healthcare were greatly exacerbated by the pandemic and severe and persistent staffing shortages. Throughout this challenging time, the QIO team assisted hundreds of providers with technical assistance, just-in-time education on essential topics such as infection control, COVID-19 strategies, vaccines, telehealth, workforce support, and best practice sharing. Now that we're sort of slowly changing focus away from just COVID, we're working to, help people refocus on their base QAPI programs and get back to basics. A lot of stuff sort of got backburnered, and we're seeing trends in a lot of the quality measures that had once been stable or still trending downward, ticking up again. So we're really trying to work with facilities to refocus and get back to basics. Bill mentioned data-driven quality improvement, and to that point, we do produce quality reports for the nursing homes on a quarterly basis. One is a standard analytic report, and it's trends of all of their quality measures. And we recently launched a readmissions report so that they can look at why people are going to the ED or back into the hospital, and what are the drivers of that, what are the top diagnoses, et cetera. Next slide. So CMS established the nursing home quality goals, improving access and uptake to immunizations, care coordination across the continuum, decreasing adverse drug events, improving resident safety, COVID safety, and advancing competency and skill and focus areas. Next slide, please. Sorry, I have allergies. The measures that we're measured on, if you will, are a combination of outcome and process measures. I'm not going to read them all to you, but there's measures focused on vaccine, the care coordination across, and adverse drugs, et cetera, just in line with the focus areas. And I have to say, Maine is doing, I don't have the data in front of me. I was looking at it yesterday. Maine's doing very well on a lot of them. Some of them, we still have room to improve. Next slide, please. It had also been asked to talk about additional process measures to consider. There's certainly the easy ones, participation in training. And I say easy tongue in cheek. We're working with the one of the Medicaid insurers in Rhode Island on a quality add-on for their member facilities. And one of the components of it was to participate in 3 learning opportunities. And I think it's still tough for facilities to commit staff time to outside training in some respects, because even though there was money attached to it, if you will, we had about 75 people register for an in-person skills fair and about 40 show up. So it was a little disappointing. And then the other thing to consider that's a big focus for CMS is adherence to components of antibiotic and opioid stewardship. There's always the other outcomes that come with that. So less C. diff, less adverse drug events, et cetera. Next slide, please. And these are just, I'm not going to read them to you, some things we've heard from people we work with. You can go to the next slide. Before I move on, I just wanted to also say what I'm focused here on is sort of our nursing home quality improvement collaborative work under the QIO program, but there are other aspects to the QIO work, and it's really in 3 buckets. So there's the stuff I've gone over in the slides, and then there's work under what CMS refers to as Partnership for Community Health, which is focused on improvement across the care continuum. And then there's focused QI work that's based on referrals. So we get referrals from CMS, we get referrals from departments of health, et cetera, to do focused technical assistance and provide tools and resources to particular facilities that are struggling. We get a list every week from CMS, for example, outlining facilities that have low vaccine rates, or facilities that have had difficulty with infection prevention surveys. And we have to do focused one-on-one assistance with those homes. Like I alluded to at the beginning, separate and apart from our QIO contract, we have a number of grants and contracts with state agencies, private funders, private parties, ACOs, et cetera. And it's all focused on healthcare quality improvement in some way, shape, or form. We're very careful about making sure it's not overlapping with anything CMS is paying us to do, but we do have the opportunity to collaborate with a variety of folks, departments of health, trade associations, professional associations, CBOs, et cetera. Next slide, please. So Bill mentioned working with Survey and CERT, and it's important to note we are not regulatory in any way. We don't have any regulatory authority. I always tell people when I go in and do site visits in nursing homes or go and work with them on site, we're not here to survey you in any way. But we are obligated. If I see something egregious, please know I will call the state survey agency. So nursing homes are not, oddly enough, we're mandated to work with them. They are not mandated to work with us in any way, shape, or form. And CMS also tells us what nursing homes we have to work with. And so it really is about making sure that we're able to show value, so that it's not just one more thing the nursing home has to do, that they're actually getting something out of it. I mentioned referrals to us. For education events, we bring in a variety of subject matter experts in addition to our own staff. And so, most recently worked with the surveyor in Maine on one of our webinars to provide the surveyor perspective on the topic that was being discussed. And I mentioned the referrals for the infection control surveys. Next slide, please. Yep. And that's it. I told you I'd get there. There we go. Happy to answer any questions. And additionally, if anybody wanted to delve deeper into anything that we're up to, I'm happy to set up a call and meet with anyone that wants to further any discussion or.
Thank you, Gail. I just want to confirm something I think I heard. So some of your work is directed by CMS. You have to work with certain nursing homes and so on. But it sounds like you also have a fair amount of discretion as long as you're addressing something in, what was it, 6 or 8 focus areas on one of your early slides. If you can, if you have the time and the resources, and you can do custom training in a state, or it sounds like you have a lot of leeway to do things within your resources, obviously.
Yeah. So if we can we interpret the QIO stuff somewhat broadly. So even if it's sort of a second cousin once removed, if it somehow is going to get back to improving quality in an area of focus, then certainly we fly it under the QIO flag. A lot of our other stuff that we do is privately funded, either by the states or granting organizations. I'm just reading the chat. The question is, in the past, it was difficult for higher performing SNFs to be able to work with the QIO, and has that changed? So interestingly enough, the CMS does it differently every single scope of work. And in this scope of work, they basically gave us a list of nursing homes that we had to recruit. And then 6 months later, they said we changed our mind and gave us a different list. So we had to recruit again. And presumably the way that they were looking at it were homes that were vulnerable for whatever reason, rural, inner city, lower performing, etc. So those are the homes that we had to formally engage. You know, they had to sign on the dotted line saying they'd participate with us. Now, having said that, we never, if we're going to have an education event, for example, we send all of the invites to every single nursing home in every single one of our states. We are more than happy to work with any nursing home. You know, several years ago, I ran a large national nursing home contract for CMS and I spent 6 hours getting drilled one time by the OIG because they were investigating complaints that the QIOs cherry-picked nursing homes so that they would look good. But the basic fact of the matter is there's nothing that benefits the QIO to do that, because we get paid on outcomes. The level of improvement that the nursing homes or hospitals see is, if it meets our targets, the targets that CMS establishes for us, then we get paid. If they don't, we don't get paid. It's no different than the value-based purchasing that the facilities and the provider community are dealing with right now. So if a home is already, say, 99% perfect, getting them to 100 is a hell of a lot harder than getting a nursing home that's at 20% to 30%. So there's no benefits cherry picking, but we certainly never turn anyone away.
Anything else for Gail? Well, thank you very much, Gail. And I know that we have reinvigorated our partnership with you since during COVID, we were all having to focus on our own things, and the regular interaction and so on declined. But we're really glad that we're now all re-engaged with one another again. Some good collaboration going on. Heidi.
Yeah, thanks. Gail, I think at the very beginning, you mentioned doing some CNA training, and that was really intriguing to me. I recently became aware that we have started training more people who have English as a second language in some of these entry-level positions, and then they struggle with passing the standardized exam, not always because of knowledge, but sometimes because of the time it takes them to get through the questions. So there was a specific example of someone who had obtained, I'm going to make it up, but it was like 55 of 57 correct, but there were 100 questions or something, so they didn't get all the way through, so then it's a fail. So I just wonder if we're thinking about doing anything innovative to, allow people with different challenges to be able to complete the training to do the job they can really do while still maintaining kind of the quality, because we want people to be trained well to do the job, but we also, I think, need to think about being accommodating.
Yeah, no, you make a really good point. And so, when we continue having these meetings, that's certainly something worth having a discussion about with both the licensing folks and the nursing bureau as well as the training facilitators. Years ago, and I could probably resurrect this too, there were a lot of folks, we were running CNA training programs in Rhode Island, and there were a lot of folks that weren't even getting into the CNA training programs because they weren't, passing the first hurdle, if you will. And so we worked with a group of folks and developed a pre-CNA training program that sort of got folks locked and loaded to be ready to succeed in the CNA training program. And that had a lot of success. Some people just need a little bit more help, to your point, ultimately will be phenomenal caregivers. And so I think it's definitely worth pursuing. I mean, we've got to do something. I mean, I'm preaching to the choir here, but, we're going out in facilities that, have 90% state, have 90% agency staffing, or, 70% vacancies. They're closing units. How many, at the beginning, someone, might have been Bill, did you say there was 20 or Gretchen, 26 facilities closed in the last?
Yeah, it was 26 since I think it was July of 2021, I think it was.
Which is both res care and nursing, right, Gretchen?
Correct.
I mean, we've had a significant number of NIF closures as well, but yeah.
It's scary, especially in geography like Maine. People, don't want to be 75 miles away from their families.
We've actually had an additional closure since then too.
Let me turn to Barbara to offer us some summary thoughts here.
Yeah, in 2 minutes, I will be brief. I just sort of higher level observations. First of all, I could probably sum all this up by saying it's really complicated. It's very complicated. I think it's complicated also by the short staffing, which sounds like it cuts across all, it's not just in nursing homes and hospitals, it cuts across all of the agencies, which make everybody's work more difficult. I'm really impressed with how collaborative the main organizations are. You are not like a lot of other states. In many states, these organizations don't really, some they don't even talk to each other. Others, there's animosity. They have different goals going in different directions. And I think you guys really stand out in terms of your efforts to and your clear accomplishment at collaborating. Residents, I know I've been working with a resident group for over a year now, and what they continue to tell me is that they, things fall through the cracks and that there are penalties and deficiencies, but then they don't see terrific correction. And I don't know if you're familiar with Marilyn Rance's work, but she talks about how it's so difficult for a lot of nursing homes to figure out the best way to actually correct the problem, that just providing the data that they're failing actually doesn't work, that there needs to be more than that. And what I hear from Maine is that that's actually happening across a couple of agencies where there is a commitment to go in and to help people figure out how to do things better. I just want to say a couple observations very quickly here from talking to residents and the focus groups that I've been doing. One of the things they talk about repeatedly is the default always to when there's surveyors or either federal or state come in, or ombuds people, that the focus tends to be on the clinical problems. And that makes sense. I mean, clinical problems can really harm people if they're not done correctly. But one of the things that they keep telling me is that there is very little focus on what they call person-centered care, which we're all fairly familiar with, that they would like to see surveyors, ombuds people, surveyors in particular, they talk about, to focus more on the quality of life issues and not necessarily less on the clinical quality outcomes. So with short staffing and all the challenges you're facing, I don't know how you expand your scope here. But that is something that I hear repeatedly from residents, that there is insufficient focus on that. And the other thing is the care plan implementation. To actually, they're all hoping that surveyors have the opportunity to look more at whether or not the care plans are actually implemented, not whether there are care plans. And I realize this is a huge challenge in the face of short staffing and all of the other challenges you meet, the turnover. But I think those are some things to look at and to consider the lack of person-centeredness as harm. So there's another sort of harm in the harm bucket. I just want to give a real congratulations to the Ombuds program for developing that CNA advisory committee. I mean, everybody talks about empowering CNAs. This is really, say, putting your money where your mouth is. This is real empowerment. Be wonderful to expand that. CNAs have great stories. They don't generally feel terribly empowered. This is a wonderful way to do it. And I would love to see this really spread across the country. The last thing I want to just mention, well, I guess two more things. One is I think we focus a lot on recruitment and less on retention, and I would like to see that shift. There's actually a fair amount of research looking at why we lose staff, and I think providers are not paying close enough attention to that, but continue to recruit. And so a bit more focus on retention, I think would serve us all very well. And the last thing, sounds like there's some good work in place here on the links between the hospital and the nursing home, but that's an area that I think everyone across the country is struggling with, and that we really need to work hard. I think a lot of it is on the hospital side. I know most hospital staff have a very unrealistic view of what people will find in a nursing home, the resources that are available, the staff that's available. And so residents and their families are often shocked when they get there because that's not what they expected, because they're led to believe something else. So that's just another area that I think you are already onto, but probably needs a bit more focus. And I just want to congratulate everyone. It's a pleasure to be part of this group. You are really innovative, so keep going.
Well, and we're so grateful that you're able to participate as well, Barbara. And thank you, Gail and Gretchen and Bill, for your presentations today, and everybody for your participation. We will convene again on September 20th. So we'll see you then. Thanks, everybody.
Thank you.